So, welcome everyone to our CCSRC rounds. We have a very exciting presentation today, Living with and Beyond Advanced Cancer, Understanding Patient Needs and Experiences. Our presenter today will be Sarah. She's a research coordinator from the Cancer Outcomes Research Program, and her work is facilitated by Dr. Robin Urquhart, who is also one of our steering committee members, associate professor and Canadian Cancer Society endowed chair in population cancer research at Dalhousie. So without further ado, I will hand it over to Sarah.
All right, thanks, Athena. Hi, everyone. Thanks so much for being here today. So my name is Sarah Scruton, and like Athena just said, I'm the project coordinator for the Cancer Outcomes Research Program at Nova Scotia Health, which is led by Dr. Robin Urquhart. She's going to be joining me today and moderating the Q&A session at the end. So a lot of the research that I've been involved in with Robin focuses on improving the healthcare system for people living with and beyond cancer. And we do it in collaboration with those individuals to ensure that we're addressing the issues most important to them. And this includes a project that I'm going to be discussing with you today. So, this is a study that our research team has been working on over about the past year, and it's focused on understanding the experiences of individuals who are living long term while receiving ongoing treatment for advanced cancer. This project was funded by the Terry Fox Research Institute and Health Canada through the Marathon of Hope Cancer Center's Network Patient Voices in Research initiative. And this funding stream supports research focused on patient perspectives across the entire cancer continuum, but with a specific focus on advances in precision medicine. So, over the past decade, advances in precision oncology, such as targeted therapies and immunotherapies, have significantly changed outcomes for people with advanced cancer. So, 5 year survival for a metastatic diagnosis used to be very low and under 10% for several cancer types. But where these survival times were once considered terminal, they're now often measured in several years rather than months. So for a specific example, metastatic non-small cell lung cancer is a type that's seen particularly massive survival gains. In 2016, 5 year survival was at just 6%, and now in 2026, this has risen to over 60% for certain subtypes as a result of treatment with targeted therapies like TKIs, which block specific enzymes that promote cancer cell growth and division. So, as a result, we're seeing a growing population of people who are living long term while receiving ongoing treatments for advanced disease. And this shift, of course, represents substantial progress in oncology, but it also introduces a new reality for patients and healthcare systems. Existing survivorship research and supportive care resources have been largely structured around kind of two cancer pathways, which are curative treatment followed by survivorship care, or advanced disease followed by end of life care. But what we're now realizing is that individuals receiving long-term treatment for advanced cancer don't really fit into either category. Now, this is a group whose cancer is being managed with treatment almost as a chronic ongoing condition, which likely comes along with several physical and psychosocial challenges. We know that these people face high symptom burden, but we currently lack an understanding on the specific challenges they face or how these are unique from those with earlier stage cancers or those approaching end of life. And this creates several challenges as we don't really have a clear definition of survivorship for someone still on treatment. And we don't know if existing supports and resources are actually effective at meeting their needs, or if we, as researchers and healthcare providers, need to be redesigning and developing supports that are specific to this population. So today I'm going to be presenting the key findings from this study, and I will also outline the process that we use to co-design supportive care interventions based on the findings. So in terms of the objectives for today, we will discuss the challenges identified by this population, and I'll highlight how these experiences may differ from those with earlier stage cancers. I will also describe the priority areas for intervention development that were identified by participants based on where they felt meaningful change was needed. And finally, I'll briefly go over the co-designed interventions that emerged from this work that were developed collaboratively between patients, researchers, and healthcare providers. And so I'm hoping by the end of the presentation, you all will have a clear understanding of the needs experienced by this group and the steps that we're taking to begin to respond to these needs. So this study was conducted in three phases, really, and phase four is still ongoing. Phase one began in the winter of 2020 or winter of 2024, early 2025, and focused on data collection, where we conducted qualitative interviews to gather insights from participants about their experiences living long term with advanced cancer. Over the summer, phase two involved analyzing the data from these interviews and identifying priority areas for intervention. And then phase three consisted of three co-design workshops, which were held in the past fall and winter. And we brought together patients and oncology professionals to design interventions to address these priority areas. And as I said, phase four is still ongoing, where we are now focusing on developing and testing the two emerging interventions. So, beginning with phase one, I'm going to briefly walk you through our methods before I move on to the findings. As I mentioned, this phase was focused on data collection and specifically using qualitative interviews to capture in-depth perspectives. We aim to recruit 20 to 25 participants across Canada, all of whom had a metastatic cancer diagnosis and were actively receiving treatment. And this included people with breast, prostate, multiple myeloma, melanoma, lung, or ovarian cancer. So we worked closely with our three patient partners who were integral members of the research team, and we developed our interviews to capture lived experiences with ongoing treatment, barriers and facilitators to addressing any challenges, and their thoughts and considerations for the development of future supports. Participants were invited to one-on-one virtual interviews conducted by me, and each interview was recorded and transcribed for analysis. After we collected the data, we again worked closely with our patient partners to analyze the transcripts using qualitative descriptive methods to identify the key themes and ensure that participant stories were accurately represented and reflected real life experiences. So in total, we conducted interviews with 22 individuals. Most interviews lasted nearly 2 hours, which gave us a very rich data set to work with. And looking at the participant characteristics here, most were diagnosed with breast cancer or multiple myeloma. The majority were female, had a post-secondary education, and nearly all had access to a family physician. Geographically, the majority came from Ontario or Alberta. People mostly lived in urban areas, and around 60% lived within 30 minutes of specialist care. The participants' ages range from 40 to 81, and the time since diagnosis ranged from 1 to 12 years, but averaged around five or six. So this gave us insight across both early and longer term experiences. So the participants first described the ongoing physical challenges that they experienced since their diagnosis. Many of these specific challenges, like fatigue or chemo brain, pain, and other side effects, are common across different cancer types and stages. But what made this population different was that they felt these side effects were unlikely to resolve. These were not considered short-term treatment effects that would fade after treatment. And instead, they were direct consequences of ongoing therapy, and the participants anticipated living with them for the foreseeable future. So as a result, they spoke about needing to adapt to these challenges rather than overcome them, which was difficult since the support and guidance were limited and tended to not be tailored to their situation. So the quote on the screen here illustrates this, and the participant states, "These are symptoms I have had for years, and I know will be with me for life as long as I'm in this." And I again want to highlight the key difference here that this is similar to managing chronic treatment-related effects rather than recovering after treatment. So the participants also described how their diagnosis and treatment affected daily life, which included their ability to work, exercise, or maintain physical activity, complete household tasks, or engage in hobbies. So they highlighted practical challenges beyond just physical limitations. So, for example, work transitions often created financial burden, which was compounded by insufficient disability payments, and unexpected healthcare costs that weren't covered by insurance, which included things like medications, physical therapy, mental health care, travel expenses, and items like prosthetics or wigs. So, one participant in this first quote here explained how budgeting around a fixed income meant they were unable to do many of the things they used to do, which made daily life more difficult. Another participant shared that they had actually declined healthcare in Canada because they simply couldn't afford it. And this was specifically regarding out-of-pocket costs for off-label medications that they hadn't been made aware of. The participants also discussed how daily routines and responsibilities were impacted by their treatment schedules, which made it difficult to make plans in advance, care for children or dependents, and manage frequent and sometimes lengthy travel for treatment. So this shows how long-term treatment impacts not just health, but also day-to-day living. So the final and the largest sub-theme discussed by participants in terms of challenges centered on adjusting to the diagnosis and trying to plan for an uncertain future. They described the emotional toll of living with advanced cancer, and they reported high levels of distress and ongoing scan anxiety, which is otherwise known as the anxiety that occurs between scans. As the participant described in the first quote here, it felt like always waiting for the other shoe to drop. Some participants said that their diagnosis was always on their mind, while others described it as feeling surreal and like they hadn't actually fully accepted it. And this was, of course, a very confusing experience as they had to consider end of life plans while often feeling physically well and at the same time holding on to hope that ongoing and future treatments would continue to be effective. They also described a sense of isolation as friends and family often didn't understand what they were experiencing or they feared becoming a burden on them. They also sometimes felt a stigma around their diagnosis. So, in some cases, people assumed they were actively dying given their diagnosis. And in other cases, they assumed participants must be cured because they appeared healthy. Several participants reflected on how adjusting to this different reality led to a revised sense of self or a new identity. For some, this adjustment was quite distressing as they had to accept the limitations of what they could do. As one participant shared in this quote here, their zest and passion for life had faded as a result. Others tried to find ways to see the adjustment more positively, and they spoke about finding a new purpose and recognizing that changes in life and priorities were necessary. During the interviews, we also asked participants about what made it easier or harder to address the challenges that they described. Many first pointed to gaps in the healthcare system as a major barrier, and specifically, they highlighted that their care tended to focus only on cancer control rather than broader supportive care needs. To participants, this looked like receiving limited information about their cancer and treatment, a lack of guidance on managing symptoms and side effects, minimal support for psychosocial issues, and difficulty getting referrals to appropriate supports and resources. So the participant in this quote on the right here described how they were shocked at how specialized everything is. And I know in research we tend to talk about everything happening in silos. So this person experienced providers dismissing issues when they couldn't address them rather than referring them to someone who could help. They also noted a lack of coordination and communication between providers, especially between cancer specialists and supportive care providers. And in general, there was a sense that follow-up care is disorganized or underdeveloped in this population. And this term is typically used to describe the phase after treatment ends, but these patients used this language, especially when their cancer was being well managed and they were having less frequent scans or check-ins. And so it left them to feel a bit confused and lost in the system. On the other hand, the patients did feel well supported when they had providers who were willing to take the time to discuss their challenges and offer information, support, and referrals, and when they could easily find supports within clinics or through advertisements. However, even when supports were available, the participants described how difficult they could be to find. The time and effort that was required to identify and access them meant that some just went without support altogether. As one participant put it here, you have to take it upon yourself to ask the questions because I think the system thinks, here we go, we're going to give you the information and it's in your hands and now you're in charge. The same person later went on to say that it felt like they had to be their own patient advocate to find resources that could help them. In some cases, the participants felt like they had a strong capacity for self-advocacy and self-management, and they were able to independently find supports and resources. But they did recognize that not all patients have this ability, especially when you take into consideration things like language barriers, limited technology access, financial constraints, or living in rural or remote areas. So, for those who were able to access supports, several credited peer support groups, cancer centers and organizations, informational websites, social workers, and other healthcare providers, and other similar resources as helpful in addressing their challenges. So, to summarize, this theme highlighted that even when supports do exist, participants face barriers to accessing them, and the ability to do so is uneven. Finally, the participants highlighted that even when supports were available and they were able to access them, they were not always a good fit for their cancer stage or experience. So, for example, some access things like exercise programs or free counseling sessions that were offered through their cancer centers. And they found these programs really helpful and said that they were successful at addressing some of the challenges that they faced. But they were disappointed to find out that often the supports were only offered for something like 6 to 8 weeks or six free sessions. And since many of the participants clearly needed ongoing support, having something so helpful be taken away so quickly left them trying to manage the issue on their own for several years after. In other cases, the participants were made aware of how their situation was unique from other cancer patients as they felt too sick to join programs that were designed for earlier stage populations, yet too well for supports that were intended for those nearing the end of life. As this quote at the bottom right describes, a participant tried to join a mixed stage support group, but they felt they were unable to actually discuss the challenges that they needed support for because these often were related to recurrence or metastatic cancer. And they were worried that talking about this might scare other members. Another participant tried to join a group that was specific to metastatic cancer, but they found the discussions tended to focus mostly on grief and end of life topics, which didn't feel relevant to their current situation. And they described this as feeling like there wasn't an emotional home where their experiences fit. Now, finishing up phase one here and starting to move into phase two, the final set of interview questions ask participants to reflect on what types of supports they wish they would have had access to and what areas need improvement for those living long term with advanced cancer. So, we worked closely with our patient partners to take these answers and identify 12 priority areas to bring forward. So this included navigation support and resource directories to help patients find available services quickly and with minimal effort. Credible information provision to ensure patients get accurate answers and to limit misinformation. Ongoing health, nutrition, and exercise programs designed specifically for each person's needs, goals, and abilities. Financial support and guidance to help people navigate work transitions, new budgets, long-term disability applications, tax implications, and decision making. Um, Expanded opportunities to connect with peers who are in similar situations to themselves, supports for caregivers and family members, opportunities for self-expression and meaning making, mental health resources, which included access to providers who have an understanding of the unique psychosocial challenges they face, practical and in-home supports, including transportation, grocery delivery, cleaning services, and finally, further opportunities for involvement in advocacy work and as partners in research. So the ultimate goal of phase two was to take these 12 priority areas and narrow them down to around 5 key areas that could be brought forward to the co-design workshops, with the idea that we might develop new supports within one of these 5 areas as a starting point. So to do this, we worked closely with our patient partners as well as members of the Marathon of Hope patient working group. And we talked about the best way to capture these perspectives. So we ended up developing a short survey to be sent around to this group, and we asked participants to rate each priority area based on importance, as well as their own experiences being treated for advanced cancer. So this process allowed us to narrow the scope of the workshops while making sure that the discussions were still centered in patient-identified needs rather than by our own assumptions of importance and priorities as researchers. So we narrowed these down into the 5 key domains, as I said, to bring forward to the workshops. So this included a one-stop shop informational resource, healthy living supports, including diet and exercise, mental health services, financial planning and support, and caregiver family and supports. These 5 priority areas we then brought forward to the first workshop. So in phase 3, like I said, we had a series of co-design workshops held over the fall and winter, and we ended up structuring these across 3 stages. So first, we held a workshop with patients only. We brought the 5 priority areas and explored what meaningful interventions might actually look like in practice. And we discussed how they could directly address the challenges described during the interviews. From this discussion, 2 core interventions began to emerge, which I'll describe here in a moment. Next, we held a workshop with healthcare providers and researchers, and this session focused on feasibility and implementation. So we asked the participants to consider what it would take to pilot these ideas as a research study, but more importantly, how they could eventually be implemented as a part of care that's accessible to patients across Canada. And then finally, we held a combined workshop and we brought everyone together. So patients, providers, and researchers. Here we integrated feedback from both perspectives and refined the ideas into more concrete, testable interventions that we're hoping to pilot in the near future. So through this process, the 2 final products that emerged included a tailored navigation support intervention and continuing professional development opportunities for providers. Now, I do want to acknowledge that we were initially surprised by these outcomes because on the surface, they don't appear to directly map specifically to one of the 5 priority areas. But when we take a step back, we can see that they actually address 2 of the main issues that were consistently talked about throughout the entire study. So, like I said, the participants made it clear that while resources might exist, they're difficult to find, they're fragmented, and they're not designed for their specific needs. So rather than simply wanting more resources, they wanted help navigating the system and accessing what is already available in a simple and coordinated way. They also wanted the providers who are delivering these supports to better understand the unique realities of living long-term with advanced cancer so that the supports can be adapted as a result. So these interventions then instead aim to address the underlying system level gaps that appeared to kind of drive these priority areas in the first place. So I'll start with the continuing professional development or CPD intervention. This one requires a bit more foundational work before it can be piloted and tested. But firstly, what is continuing professional development? So CPD refers to both formal and informal learning opportunities that allow healthcare providers to retain, enhance, and extend their knowledge and skills throughout courses, conferences, workshops, lectures, mentorships, and other forms. But the goal is to make sure that provider skills evolved alongside changes in the healthcare system and alongside new evidence and best practices so that they can continue delivering high quality, effective care and ultimately improve patient outcomes. So in the context of this study, the idea was to use CPD to increase the awareness and understanding of the unique challenges faced by this population and to better equip providers to respond to those needs. So more specifically, what would this look like as an intervention? So the objectives would be to improve providers' understanding on how this population's needs differ from those treated with curative intent or those nearing end of life, to increase awareness of available supports and strengthen referral pathways, and to support the tailoring and adaptation of existing services so that they better meet this population's needs. Because this intervention has not yet been developed, I can't say exactly what form it will take, but based on the ideas of the working group members, I can give some examples. So Within the priority area of healthy living and exercise, CPD could target physiotherapists or exercise physiologists who are involved in rehabilitation to increase their understanding of the long-term physical challenges that require ongoing support and how abilities may be impacted by treatment side effects. It could also target nutrition professionals, for example, to support patients who may be interested in weight loss rather than the more common cancer care focus on weight maintenance or gain. Um, in the mental health domain, CPD could help practitioners to learn more about adjustment challenges, changes in identity, and the realities of living with prolonged uncertainty, as well as increase their capacity to support caregivers or family members of patients. So this would likely extend to oncology providers themselves as well to increase their capacity to manage challenges outside of cancer control. So there's a few examples, and basically this intervention could take on many forms, but this means that there's significant groundwork required before it can be developed. So you'll notice the pause symbol that I put on the slide because these foundational steps need to occur before we can pilot test anything. So this would include conducting a needs assessment to identify knowledge gaps among providers, identifying resource constraints and potential implementation barriers, and determining which CPD delivery format would be most effective for each provider type in achieving the intended outcomes. So the patient navigation program is somewhat more tangible because we have a clearer sense on what this could look like and how it could be implemented, particularly because navigation programs have demonstrated success in other patient populations. And what do we mean by patient navigation? So this refers to activities that facilitate access to programs and services for patients, families, and caregivers. It involves supporting individuals navigating the healthcare system, promoting continuity of care, and identifying and addressing barriers that may prevent them from accessing appropriate supports. But in summary, it basically ensures that patients are not left to navigate complex systems on their own. Patient navigation has taken on several forms in the past, so it can be delivered digitally through websites or apps. It can be telephone-based with remote check-ins, or it could be delivered in person within clinics or cancer centers. The type of navigators can also vary. So in some models, there are healthcare providers, healthcare professionals like nurses or social workers, and in others, they may be trained peer navigators, meaning other individuals with a lived experience of cancer. Several navigation programs have been evaluated to assess their effectiveness in improving patient outcomes, and the findings of success are pretty consistent. So as you can see here, they've been associated with reduced unmet needs and psychological distress, decreased emergency department visits and hospital use, fewer missed appointments, lower financial stress, and reduced caregiver strain. They've also demonstrated improvements in quality of life, activities of daily living, self-management capacity, access to care, guideline adherence, and care coordination. So what's important to note is that these factors were nearly all described as challenges by the participants in our study. So this highlights how relevant this intervention would be. So for this particular population, we knew that navigation would likely look a little different than existing programs since these individuals face such unique needs that change throughout the cancer trajectory. So during the final co-design workshop, we divided the participants into small groups and we asked them to identify the key considerations and core principles that would be essential to designing a successful navigation program, which resulted in these 6 core principles, and I'll briefly go through these one by one. So the first key consideration was the importance of using a stepped care approach. By this, we mean offering different levels of support and recognizing that not every person will need the same intensity of help, as well as that support needs may change over time. So the goal is to create a navigation program really that meets people where they're at without overwhelming them or providing unnecessary resources. So we can think of the intervention as being provided in tiers. So the bottom tier, for example, could include access to informational resources like guides, FAQs, or a Q&A forum. And the top tier might involve connection to a professional navigator for more personalized support. For this to be effective, this probably requires the use of screening tools to help direct patients to the level of support that they currently need. And this would ensure patients receive the support that fits their situation, and it would allow providers to save time and allocate support more efficiently. Related to this, it's clear that the navigation program must be flexible and capable of adapting to the changing needs of patients. The level and type of support that a person requires can shift over time depending on their treatment, symptoms, prognosis, and personal circumstances. So, as a result, we need to consider the entire trajectory of care from the moment of an advanced cancer diagnosis through ongoing treatment and all the way to end of life care. And I think ideally, a navigation program for this population would provide resources and supports for each phase so that patients can access what they need exactly when they need it. So we also have to consider that there's no one size fits all approach to navigation, and needs will differ between individuals. So this highlights the importance of designing a navigation program that's tailored and personalized. This fits well within the stepped care approach, but even within each tier, different methods may be required to meet specific needs. So, for example, peer navigators can be especially helpful for psychosocial and emotional support by offering empathy and advice through shared experiences. But certain informational and physical needs, such as understanding treatment side effects or accessing specialized services, may require input from a healthcare provider. So, if we combine the past three considerations, we can summarize that ideal navigation matches each person to the right type of support for the right need and at the right time. During the workshop, the participants also emphasized the importance of leveraging technology to improve accessibility, and this would allow navigation to be an anytime and anywhere type of support. Some suggested even using technology like AI to filter patient concerns and direct them to appropriate resources, with the option for person-to-person support when needed. At the same time, we talked about how the use of technology also requires considerations for vulnerable populations who are likely to benefit from navigation, but who may have less access to or comfort with technology. So this includes people living in rural areas, older adults, or newcomers, or those with language barriers, as an example. So practical solutions might include having telephone-based support or other low-tech alternatives to ensure all patients can access navigation, regardless of their circumstances. We also talked about the importance of just-in-time access. So during the interviews, the participants made it clear that delays in accessing supports and resources caused them distress that could have been avoided had they been made aware of what's available to them at the time of diagnosis. So the participants in the workshop made it clear that patients need to be offered navigation support from the time of diagnosis, and it be made available at multiple time points across the cancer trajectory as needs change. So a multi-pronged approach can help ensure access here, which would include things like referrals from healthcare providers, along with QR codes and clinic waiting rooms and advertisements through social media groups as a few examples. So finally, the group emphasized that, of course, all information and advice, whether via a navigation website or through a human navigator, must be evidence-based and kept up to date with the latest research. So this would require regular review and updates to ensure information is accurate. And it likely involves training and input from healthcare professionals to ensure that content is aligned with clinical standards. The goal is to provide reliable guidance that patients can trust at every stage. So, where are we now? So, to move these interventions toward pilot testing, we're working on assembling study teams, exploring funding sources to support the development and testing, connecting with existing navigation programs to identify collaboration opportunities, refining the interventions into a final product for testing, and of course, preparing the CPD intervention, including the needs assessment that I mentioned. So to wrap it up, what we've seen is that people living long-term with advanced cancer face challenges that are different from those with earlier stage disease, and many of the supports that exist are ineffective at meeting these needs. This is made even more challenging by the fact that accessing supports is difficult and guidance from care providers can be limited. The participants in our study highlighted several priority areas such as information provision, navigation support, healthy living and exercise, financial planning, and more. But the big takeaway that I'll leave you with today is that before we develop any new resources or supports, it's important that we're equipping patients with the tools to access these supports, and we need to enhance the capacity of the providers who offer these supports to care for this unique population. So that's it for today. I'd like to quickly acknowledge TFRI and Health Canada for funding this study, for the patients in the Marathon of Hope Working Group for being so supportive of this work, and of course for all of the participants who took the time to do an interview. And thank you to all of you for listening to this presentation as well.